treatment. We are delighted to welcome Assistant Director Fortney from Johnson County Mental Health to talk with us. Tanner, let's get started. Since the Crisis Stabilization Center opened November 7th, who's counting those dates, what are you seeing in terms of demand? How many people are being served so far? What does a full day at the center look like?
Thanks, Jennifer. Well, first of all, thank you so much for having us here this evening. It's always a joy to be able to talk about a lot of the great work we're doing both at the county and at the mental health center. So since we opened the Crisis Stabilization Center on the adult side, I'll kind of give just a little bit of background on that too. Earlier in 2025, about this time actually, the Board of County Commissioners have approved us to be able to hire additional staffing so that we can really make that facility a reality. And it's housed over on our CCS campus over in Shawnee. And since we opened that facility, we've had, both in 2025 and 2026, we've actually had 96 individuals that have been admitted. In 2025, as you might expect, it was pretty low because we were still getting our staffing levels built up. And so the vast majority of those have been in 2026 up to, and those numbers are through April 20.
All right, so now when someone arrives at the Crisis Stabilization Center, how long are people typically staying, and where are they going after they stabilize?
Yeah, so typically the average length of stay is about 4 days. Now, typically they can stay 23 hours in what we call our observation beds, our observation chairs, which are the chairs where people can come in. It's all voluntary, they're not required to be there for 23 hours, but they can stay there, and then usually after that, about 20% of the folks that have gone through those observation chairs usually then check into actually inpatient, and they can stay there for up to 72 hours. So that's typically the average length of stay. And right now we have, on average, our daily census is about 5 to 6 individuals, and we have a total of 14 beds and 2 chairs that we use. Following discharge, about 65% of individuals, once they leave the facility, they usually are discharged back into the community, back into their own private home or a home with their family. About 15% usually go to higher level of care, particularly inpatient hospitalization. The remainder can go to any number of different areas. Sometimes it could be other forms of hospitalization. We've seen quite a few, everybody averaging all the way from the age of 18 all the way up to individuals that are going to be classified as senior citizens, so 65 and older. So it's really a wide range. I don't know if we could really say that we have sort of an average person that we would normally see at the facility, so it really varies. But as far as how people come to the facility, a lot of it is through our partners in law enforcement. We have, as many of you know, we have co-responders embedded within our law enforcement agencies in the county. So oftentimes when they're having crisis stabilization calls, they're able to bring them in if they're not able to stabilize them on scene. So that's where a lot of our stuff comes from. We also have other staff that can make those referrals as well.
The first few months of any new effort teaches us something. What are you all learning so far about what it takes to make this work well?
So I mentioned that in the beginning that we have a lot of people that are everywhere from 18 to early 30s. We do have a lot of folks that are in that age range. And one of the things that we found is the amount of additional support that group actually needs. Typically, we often think it might be more of our senior citizens or individuals, but it's typically individuals that are actually in young adulthood and also individuals that are in our IDD population. That's where a lot of our support comes in. We're seeing that there's a growing need for that, and as we continue to look at our staffing in the future, we're going to be looking to find ways to find additional support. One of the other things that we've learned in our facility is we spent, in the lead up to this, we spent quite a bit of time during COVID with doing some remodeling in that facility, particularly in our lower level area, to make this work. And we thought we had a very, very good setup where we could get, if MedAct brought people there, if law enforcement did, a great path to be able to get them into our facility. But unfortunately, the best laid plans don't always work out as well as we wanted, and we found there's been some trouble with gurneys, there's been some trouble with individuals that might have mobility issues, and so we've had to adjust a little bit about where some of the functions are located within our facility to better accommodate some of our partners.
That makes great sense. And finally, how does the center fit into the larger mental health system of Johnson County, and where are the critical gaps?
Sure. So I think where the biggest critical gaps that we see is There are individuals clearly who do need inpatient treatment in long term. And the state of Kansas for many years has struggled with being able to have an adequate number of inpatient beds, especially when you're looking at Oswego State Hospital. It's been very lacking. The other piece that we've seen is there's really a huge demand for transitional housing as well as supported housing. That's something that is huge and it's going to continue to be a problem, I think, as we move forward. So the more we can do to partner with other community partners and other organizations to be able to continue to build upon that and help individuals, especially those that are in our homeless population, to be able to get them into that stable housing, that in turn leads them into becoming outpatients with us, outpatients with other private providers, places where we can provide that ongoing support to prevent future crisis things that they might have, different episodes, and also to be able to prevent them from continually going back through the crisis system. Because, as I always like to tell people that aren't as familiar with mental health, our crisis center, it's wonderful, it's great that we have it, but it's sort of like the ER in physical health. You don't use the ER as your primary care doctor. And that's not what we want to see here. We want people to be able to see their primary care doctor, in this sense, being more like the mental health center in our community partners. So that's really the goal we're striving for.
Thank you. So what we're hearing tonight is clear. The center is doing exactly what it was designed to do. And at the same time, there is more that can be done. We'll be talking more about housing later tonight because as many of us know in this community, stabilization is only the first step. And with the Crisis Stabilization Center now open, we can resume work this summer with Tim DeWeese, the Director of Johnson County Mental Health, on bringing together local hospitals, community mental health, and the Kansas Disabilities and Aging Department to take a hard look at the involuntary treatment needs of Johnson County. Tanner, thank you so much for